Joyce, 1 minute. Yep.
Hi, good afternoon.
Dr. Joyce, you can start.
Yeah, hello everyone, and welcome to yet another interesting episode of Beauty Because Club. Let's Talk Beauty. Today we have a very renowned cosmetic surgeon who's basically a native of Egypt but now practicing in Dar Al Shifa Hospital in Kuwait. He is a very passionate cosmetic surgeon who has done a fellowship from the European Board in Brussels in Belgium. He's also done a fellowship in the Advanced Cosmetic Techniques from Germany, and he's a member of the American Society of Plastic Surgeons and a very good friend of Dr. Karthik. His passion in cosmetic surgery is so important that he's a very enthusiastic attendee in all the international conferences and workshops. And today we have him in our show to talk about facial rejuvenation. So,
Dr. Nadi, I'm very happy to invite you to our Chennai Plastic Surgery this meeting. And Dr. Joyce, you introduced about Dr. Nadi. And one more thing, we attended a congress, that is a dissection symposium in Amsterdam. It's a place called Utrecht. It's a beautiful place, and we both are there for 3-4 days. And you don't believe, a lot of faculties were there, and most of the attendees will go on wanting Dr. Nadi to teach us some more than that. Like the teachers, he's very knowledgeable, and he is very skilled, and all the girls will be behind him for he teaches very nicely and explain very nicely the things. His knowledge is phenomenal. So we want to learn a lot from you, Dr. Nadi, and over to Dr. Joyce.
Thank you, Dr. Karthik and Dr. Joyce, for the very kind and invitation. Actually, a small personal remark about Dr. Karthik. Regardless of any scientific issues, Dr. Karthik is a very good personality that I am very happy to know him. He, we met maybe 5 days in Amsterdam for cadaveric dissection course, and since then we are friends and we keep talking to each other. He's really an example model for all the young surgeons and even young persons in India who can learn from him scientifically and personally. He's a good man. Thank you.
Thank you, Dr. Nadi.
yes. Dr. Nadi, we all know that the geographical variation with respect to patients is very prominent. Like here, we have patients who have different cosmetic concerns. So, with respect to that, I would want to know that what are the facial cosmetic concerns that your patients have?
As regards the facial cosmetic surgery, we deal with different kinds of patients and with different interests, and these interests may be different from country to country. But one thing I would like to focus on. First thing is that you have to learn what is normal, because you are met with patients with different requests. Maybe they request something bizarre or unusual or not written in the books. So the real judge in these issues is that you have in your mind what is normal, where the brow has to lie relative to the eye, where is the medial canthus has to lie relative to the lateral canthus, what are the normal dimensions of the nose, the width relative to the length, relative to the rotation of the tip, what is the relation of the upper third to the middle third to the chin, to everything, to the angles, the nasofrontal angle, the eye angle, the nasolabial angle, the submental neck angle. All these you have to have a good idea in mind, so that once the patient comes to you, you will make an assessment of this patient, and then you learn by this examination what deviates from the normal that you know well. And when you know what in this patient, this respective patient that deviates from normal, only at this time you can decide how to help him and how to retrieve him back to the normal. Otherwise, if you don't, if patient comes to you and want his her eyebrow to be like this, for example, and you don't know what is normal or what is the standard of beauty in this area of the face, then you can end in something bizarre, or you give him a treatment that may worsen rather than improve his condition. In the face, we meet a lot of requests related to the cheek, to the depletion of the cheek, to the atrophy, to the border of the mandible, nose, the eyelids, the even the wrinkles in the forehead, or even the length of the forehead itself. And then we try to manage it according to the request of the patient and according to the standards of the beauty in this area.
Dr. Nadi, it's actually what you explained is really true to all the young plastic surgeons who is watching this show. Because first we need to know what is normal, what is aesthetically pleasing look. Then only we can advise to the patient what they are asking is correct. You are very correct in whatever you're told is perfect for the younger generation who started his cosmetic practice. Second thing, Dr. Nadi, what is the commonest procedures you do in the face? I know that you do a lot of rhinoplasties. We are planning to discuss it a little later. But the other procedures, what are the other commonest procedures you do it in the face in your place, so that we want to know more about it?
And in our area, we do a lot, yani, Botox, fillers of the cheek and of the lip, and the fillers of the angle and border of the mandible. I do a lot blepharoplasty, and one thing that not many people do, but I do often also, is shortening the forehead, because we are met with patients with long forehead or receding hair. So I do shortening the forehead. We do buccal fat pad removal. We do upper lip shortening in the patients who have long lip. And some things, yani, maybe unique to me because I do it more than others, is the cheek dimple, because it's requested often in our areas. And something that I do, maybe I am the single person, is the chin dimple, because I created the technique. So I have not met somebody who can do it effectively. Yeah, a little, because maybe I created a technique that proved it to be good. So I do it often also. And
Superb.
others, but I don't remember everything.
Dr.
Yeah,
Karthik,
definitely.
I think this is very unique, no? The chin dimple. Here we
Dimple.
don't have many requests, or rather, our patients are not so aware of it. But that's a very nice thing that he's doing.
Yeah.
Yeah.
Uh, since you are designed the technique, and like you get a lot of requests. Like Dr. Joyce, one more thing. Unless otherwise we tell the patient these things, they don't know that we can create it.
Yes.
Like
Mm.
we need to be aware of those things before, then only we can tell the patient that yes, it can be possible. Dr. Nadi, why can't you explain about the chin dimple and the cheek dimple, why they come to you, and like what is the commonest method? Can you little explain about the procedures a little, so the patients also aware what we do? Chin dimple and
Okay.
the cheek dimple.
Okay. This cheek dimple. First of all, the dimples, any dimple that is added to any face will give some beauty to it, because always this cheek dimple appears when you smile. So it is always associated with smiling. So when you add a cheek dimple and the patient smiles, it gives them much beauty. Before, yeah, of course, I learned the technique of cheek dimple from other senior surgeons. That later I changed it completely. But before I really started to do my way in the cheek dimple, I met the patients who coming for up for other procedures in my clinic who have already natural cheek dimple, and I took measurements, and by these anthropometric measurements I learned the real position and the shape and of these dimples as relative as in relation to their length, their direction, and their distance from the angle of the mouth, and their distance from a vertical drawn from the lateral canthus. So I decided the real position and the shape and depth of the natural dimple, and by deciding this, I now try to recreate them in my patients. Uh, I have done a lot of these cheek dimples. I do them under local anesthesia, and they take around 10 minutes in my hands. And when I did a lot of them, I learned many things that you can consider a relative contraindications to these cheek dimples. These relative contraindications include dental caries, dental filling, like smoking, permanent fillers, previous cheek dimple that were infected, and presence of orthodontics on the mouth. If a patient has like one or two of these, maybe I can do for them a cheek dimple, but I can be cautious. If they have like three or four of these risk factors, maybe I try to avoid doing it to them because the incidence of infection becomes higher. So after examination of the patient, uh, if they have a dimple on the other side, I try to recreate. If they don't have a dimple, I try to follow my measurements that I gained by anthropometric measurements. Then I mark, then I give local anesthesia. Then I transpose the marking that was drawn outside to the inside of the mouth, and I create only a small incision inside the mouth. And by creating this, you try to decide where is the Stenson duct opening to avoid it and to avoid its injury. And I create about 5 millimeter opening, and I introduce a scissor to do blunt dissection. So I think with my technique, and I after injecting xylocaine and adrenaline, I narrow constriction of the blood vessels, and I don't cut anything. So in all my cases, there was no chance of big bleeding, no big hematomas, no sensory loss, no affection of motor nerves. So I consider it to be a very safe procedure. After creating this incision, I use the special sutures called the Novafil. It's permanent sutures, and I choose only this suture because it's fitted on a very long needle, maybe 40 millimeter or 37 millimeter needle, so I can cross the whole inside of the cheek, outside, then inside, in one pass. No need to go out and go in again. And then I tie the knot, and then I close the mucosa over it, and then the dimple is created. This is the basic technique. Sometimes I add to this technique like a piece of silicone urine catheter. It's cut like a macaroni, and I tie it as a tie over stent from on the outside of the skin. This helps to give the cheek dimple a longitudinal appearance, because many people ask for it to be more longitudinal or more oval rather than a small point. And this stent also, when tied on the outside, I leave it for 1 or 2 days only, prevent, because when you dissect it through a very small opening, you don't have a chance to control any small bleeding inside. So tying this stent to give the dimple a longitudinal appearance, and also prevents any blood collection or hematoma to collect in this. And it's a simple and usually goes easy. And this dimple usually survives for 1 or more years, maybe like 60% of the patients, the dimple lives with them more than 1 year or forever sometimes.
Dr. Nadi,
Uh,
I remember. Yeah, like the patients are like so particular about how the shape of the dimple they want, and like the position also sometimes they come up with a already like planned with one, like we plan somewhere but they ask some other place. How will you like take this, and how will you explain them, okay, what is the normal dimple and how will you take it forward when the patient had a specific choice of the size of the dimple, the sense shape of the dimple, like do you want the oval
uh,
or round, or like.
when I tried to look on the normal dimples, whether chin or cheek dimples, and searched Google and see them in the normal persons, I found the dimples have very different shapes, and starting from like a small dot, like from sometimes they don't appear except after smiling. Sometimes they are exist all the time. Sometimes the patient has two dimples and they are not the same. They are not the same in shape or in depth or anything. They are very different. Even in the chin dimple, I found dimple like a small dot or rounded, sometimes oval, sometimes Mercedes, even Mercedes shape. So uh, you have to reach a compromise, because maybe you will come to someone and make for them a Mercedes shape, and they come to you and complain, no, we want it to be like a longitudinal shape. Sometimes you do to them a longitudinal shape and they say, no, we like it to be like a rounded or like a small hole or a small dot. So the compromise that I reached that can satisfy most patients and still also technically visible and can be done is the oval shape. يعني I try to make this dimple longitudinal. I try to make this dimple also longitudinal, and this satisfies maybe 99% of population. Maybe if you have seen some even some dimples, natural dimples in some people, like Princess Kate Middleton in London. She has a dimple that starts from here and go back down to here. Maybe, although this is natural and beautiful, but if you do it to somebody, of course they will sue you. So you cannot do
I know.
everything natural to everybody. You have to reach some compromise that can satisfy most patients. As related to the position of the dimple, I found that the dimple usually, when I did my anthropometric study, I found many shapes like round, even comma shaped dimples also exist. But really, this comma shaped may be very difficult to create surgically. So you choose something that is already achievable, yani, that you can
Achievable.
do, because you
Okay.
cannot do everything. I found the cheek dimple to lie on a line drawn from the intertracheal fossa under the tragus to the angle of the mouth. The center of the dimple lies about half centimeter below this line, and also lies about 2.8 centimeter from the angle of the mouth.
Okay.
And when you look for the direction of the dimple, usually it points between the lateral canthus and the lateral limbus. This is where you put exactly the dimple. And you plan its length to be about 1.5 centimeter in length,
Okay.
and you
Okay.
put it in this position. Probably it will become correct.
Okay. The incision what you make inside, is it matters, Dr. Nadi? The incision what you make inside, that's the size which decides the outside more outside dimple what you're creating.
Yeah, look, when I decide, I put a line from the higher point to the lower point of the dimple. This line is around 1.5 centimeter, and
Okay.
it's drawn with a like a blue or black marker. And sometimes you give the patient a mirror and you press this with the pen like this, and the patient looks in the mirror, and you tell her, this will be your dimple. You like it? If she likes it, okay, that's fine, that's good. Then I bring a needle. After giving anesthesia, I entered it in the upper. But without penetrating the mucosa, and my nurse put a dot on the inside, and I come to the lower part, and I enter the needle until it pushes the mucosa without piercing it, and also put. So now I know where I have to create the dimple inside the mouth, and between these, usually these lines lie about 7 millimeter in front of the Stenson duct of the parotid gland.
Okay.
But if you find them very close to the duct, you have to go a little bit in front, because you can accept that the dimple is 2 millimeter in front, but you don't accept to injure the duct, and then you do this dimple.
Okay. Dr. Nadi, for this chin dimple, how will you approach it? You intraorally, where will you make a cut, and how will you go and take a bite from? Like, can you just explain some more? Because I never done a chin dimple. I done a lot of cheek dimple, but I never done a chin dimple in my practice.
Yeah, this chin dimple is very interesting, because maybe about 7 years ago, one patient came to me and asked me, I want to do a chin dimple. At that time, I don't know how to do it. And this patient had filler in her chin, fortunately. So I had an excuse to tell her, please go until the filler disappears and then come back, we'll do it to you. And then I thought she will not come back and I will be safe. But again, she came back, and so I had to do something. I tried to think, what is the dimple? The dimple is like there is here the skin, and then the fat, and then the muscle mentalis, and then the periosteum and bone.
Yes.
What I thought is that this dimple is just the skin and dermis very close to the periosteum without intervening tissues. So I thought if I could cut these tissues in the midline so that only the skin become close to the bone, I could create a dimple. I tried to do this by many ways. And every time I improve the technique, I get a dimple that is better than before. I did this maybe 3 or 4 times until I reached the technique that I use nowadays, which proved to be successful in maybe 99% of patients. Uh, this technique starts by uh, defining the midline. And sometimes defining this midline is not very easy, because sometimes the chin is asymmetric. Sometimes this is bulging, this is flat. So if you put it in exactly in the midline, one side of the chin appears full, one side of the chin appears smaller, and the line appears deviated. Uh, Sometimes the chin itself is symmetric, but it's the midline of the chin is not the midline of the face. So if you put the midline, the line in the midline of the chin, it will be not in the midline of the face. Or if you put it in the midline of the face, it will not be in the midline of the chin. So you have to decide. You have to. Usually, I draw one line and I bring everybody in the room: the nurse, the relative of the patient, and the patient itself looks at the mirror, and I ask them if this line is in the midline. After I take all opinions, and then I try to decide the midline or modify my first line. Uh, of course, like if sometimes there is fullness on one side of the chin, so you try to put it exactly in the midline of the chin, and then try to correct the chin asymmetry with fillers later, after you make the dimple. Because if you put it to one side to appear symmetric at the start, you'll not be able to correct it later. Okay, after I decide this midline, I divide it into thirds. One, like starting from here to here, I divide this area into thirds. And then the center of the dimple will be inside the lower third. يعني I ignore the upper, the middle, and slightly in the upper part of the lower third. I put a line. This will be the middle of the dimple, or the deepest part of the dimple. And then this midline, I draw one line half centimeter lateral to it, and then another line half centimeter lateral to it. The same on the other side. So I have 5 lines. These the 2 medial lines is demarcate the excision, because I excise some fat, and the 2 lateral lines decide where I put the stitches of the stent. Now I have marked all the lines that I need. I start to inject local anesthesia. This dimple is not do not have much risk factors like the cheek dimples, because cheek dimples, you make a communication with the inside of the oral cavity, so it has a high liability to be infected if there are permanent fillers or there are dental caries. This chin dimple is safe, and even if the patient have filler or have permanent filler or have dental caries, these do not affect the much about the infection of the chin dimple. Then one important precaution: if a patient that presents to you have a filler, just you can tell her that she can come out with some of the filler gone, because when you open and you go inside the chin, you meet the filler, and some of the filler is extruded outside. So this can result in decrease in the projection of the chin, and sometimes the filler is extruded from the left more than the right, or the right more than the left. So there can be some small asymmetry that can be corrected later with filler. After I decide the line and where should be the dimple, I make a small incision 5 centimeter below in the labiomental crease here, in the submental crease here, and then through this incision I do everything. I introduce a very small needle, a very small scissor, and then I cut like the side, then under the skin, then above the periosteum. So I have one block of subcutaneous fat completely separated from the surrounding tissues. Then I introduce an hemostat and I pull it out. Then after that, I have a curette, a small curette, about 4 millimeter or 5 millimeter curette I introduce, because now after you excise this fat, the edges are not tidy. They are irregular, and some tissues are avulsive. So you have to make it regular. So I introduce my curette directed toward the dermis, and then I make a small curette to make surface smooth, and then again I direct it toward the periosteum, and I curette until there is no irregularities there. After doing this, I have also suture Novafel 30, also in a very long needle, like 37 millimeter needle. I make a hole with a big needle here, like 16 gauge needle. Then I introduce through the hole that I incision that I created in the submental area. I enter the needle, I grasp the periosteum, and then I come through the needle that I created by the hole that I created by the 18 gauge needle. Then I come back through the same opening, and I go through the dermis at the point that I told you in the lower third. Then I come through again the opening. So now you have the suture grasping some periosteum and some dermis, and then I tighten the suture, and then you'll find a very good dimple appearing. After that, I have like this macaroni stent that I create from sometimes from the silicone urine catheter, sometimes from the disposable tube of that we use for infiltration before liposuction. I create a lot of them. Then I put it here. And then there were 5 lines, two, and then 1. The lateral, the most outside lines, I make like a transverse matrix stitch and tie it over the stent before I close this incision. Why? Because when I tighten the stitch, it pushes down and it evacuates any remaining hematoma or any remaining blood that is still in the wound. Then I close this and we have finished. I leave this stent for usually 4 days. But why 4 days? Because most of the edema that occurs in any surgical site usually occur between the 3 to 5 days. So I make it 4 days to cover the tissues to avoid collecting edema or seroma during healing. And I don't leave it much because if you leave it more than 4 days, I found that the stitches that I take here leave stitch marks. So I try also to reach in this issue to reach a compromise between leaving it too short and developing hematoma or leaving it too long and developing stitch marks. Then everything will be okay. I intend for both the cheek dimples and the chin dimples to be deep at the start and I warn patients about this. I tell them because most of the patients they want the dimple. Once you remove the stent, you found a very beautiful dimple. This cannot be. I have to make the dimple very deep from the start because by experience I know that after 1 month or 2 months they will fade by about 25 to 30%. So by making it deep, I compensate for this fading that occurs with time, and I assure the patients that the dimple will, after 1 or 2 months, will reach a stable level that will be beautiful at this time. So they shouldn't ask me about why she's deep, why it is deep from the start. I make it deep for this reason. I give antibiotics and analgesics, of course.
Very beautifully explained, Dr. Nadi. What, Joyce, what are you feeling?
No, if there is a filler, do you prefer to dissolve it before you do this procedure?
No, no. If there is filler, I don't prefer to dissolve it because, in the chin dimple, maybe the infection rate in my hands maybe 2% only, and with the presence of filler, it is maybe 4%. So it's not much increase. I don't find any need to remove the filler first because already the filler is there and it helps some function. So why remove it? Maybe after we do the dimple and the dimple becomes stable, maybe the patient can add some filler, no problem. But I don't recommend.
Actually, Dr. Nadi, when you told me about the story, how you first patient, how you started doing the chin dimple, it remembers me that the first cheek dimple, what I did maybe 12 years back, when I see, like immediately I'm entering into the practice, one Malaysian patient came and she's having a flight in 2 days time, and she wants to get it done immediately after the consultation. I'm so scared. I never know something. We can create the cheek dimple, and our textbook not much explained about this also. So I don't know what to do. So once I sent her out, and I told, okay, afternoon we'll do it because I want to buy some time to prepare and study something about the cheek dimple. Then I opened the YouTube and click a cheek dimple, and there is a one good procedure video came. I saw that video, and then I did it at a local for that lady, and but came out really well, and extremely she is happy. After that, probably I have done probably 7 to 8 dimple, but sometimes I am afraid to do for the modeling people because whether it will be like a very natural looking dimple or even a little bit of artificialness to the dimple will lead on to a trouble to the models and that actors when they're asking for it. So I'm little cautious. I remember one Singapore girl, we did a lot of procedures for her, and she asked for the dimple. I was little skeptical because she was a model in Singapore. She's a model in Singapore, so I was a little skeptical what to do. So I told her, I'm a little afraid to do on you because you have to face the camera. Sometimes if it is looking not natural, it's a bad thing. I don't want to do it upon you. But she said one thing, Doctor, I believe in you and I am confident in you. You do it, it will be good only. But hesitantly I did it, but it came out really well. And I used to see her in that some of that modeling pictures when what she shared in the Facebook. It really looks natural till today. But I never did a chin dimple. Probably, like nobody asked it. Probably after this program, few people might know that it can be created, and they'll come to us on the chin dimple creation.
Okay, I will send you everything. Don't worry, just start.
Definitely, we'll get you help only when I get a first case. Okay.
Yeah, yeah, really, when patients challenge us by asking us requests of things that we don't know, they are forcing us to learn something new. Because really, if this patient, that patient 6 years ago did not insist on me to do a chin dimple, I would not have created anything. And even the patient challenged me again when I did some of the chin dimples. Maybe like 0.5% of the patients, the- and unfortunately, they are one of some of the patients who have the best chin dimples that I have created, came to me to ask me to remove it.
Okay.
And this was strange because I don't know any way to remove it.
The only thing
And
what I feel is
also,
you can. Yes.
I thought
Yeah.
of a way how to remove this, and I tried to reverse the technique again, and I tried to devise a technique to remove a chin dimple, and also it succeeded. So I know how to make it and how to remove it finally.
Okay.
Okay. So we have spent a lot of time in the dimple itself. So now we move on to the peri-orbital rejuvenation, because it's another 20 minutes we have, so that we'll talk about the peri-orbital rejuvenation. See, Dr. Nadi, you said that you do a lot of upper and lower eyelid blepharoplasties in your practice. But in our practice, we don't see much of the blepharoplasties for a lot of reasons, because our Indian skin won't age faster like white skin people. But I don't know, for some reasons the people are not coming to us for the blepharoplasty so often, like how you are telling in your practice. So can you just explain us what is the commonest reason for the blepharoplasty in your area, why they come to you for the blepharoplasty, and what are the procedures you do peri-orbital region for making the patient happy?
Yeah, yeah, we face some patients, yani, so maybe in our practice it also is not very common, yani, because the most common things that we deal with nowadays is the body contouring and breast surgery. This is what we face most of the time. But we face also a good number of patients who request blepharoplasty, mostly for wrinkles around the eyelids. This is for the upper eyelid, and for the bags in the lower bag, or the fat, bulging fat in the lower eyelids. First thing, we try to assess the brow position, because sometimes the excess skin in the upper eyelid only results from brow ptosis. So if this is the case, we try to suggest to the patient something to raise the brow, either by uh, Botox, by threads, or by uh, surgical brow lift. And only when the brow is in a normal position, we can assess the real excess of skin in the upper eyelid. For the eyelid surgery, we do it most of the time under local anesthesia. We give xylocaine. Of course, we mark first. We decide the good position of the supratarsal crease, and then mark it medially and laterally. We decide if there is any fat, bulging fat before infiltration of anesthesia. Then decide the excess skin and mark the upper limit of the incision. We give the local anesthesia, and after giving it some time to take effect, we excise the skin, maybe excise some part of the muscle, and then we handle the fat. We add some more local anesthesia, then clamp the fat, then remove it, and the operation is done, finished. It's not easy and does not take long time to do it.
Uh, the
Okay.
the here the see people, the problem happening nowadays is because Even last week, I had a ideal patient for the lower eyelid blepharoplasty with a lot of fat prolapse in the lower eyelid, the fat bulge in the lower eyelid. But that guy doesn't. They're all afraid to go under the knife around the eye because they fear that something happened to the eyesight or something like that. So he's pushing me to do a filler. It's already a big bulge. I need to use at least 2 to 3 fillers for like camouflaging the thing. Even I told him it won't look very natural because we are going to give a lot of volume to the just adjacent to the fat. So you have to spend a lot of money. Like if you calculate in India, if you calculate surgical price will be cheaper than the filler price. That's a lot of times. So
Sometimes really
yeah.
in the lower eyelid, maybe the fat should have a bigger role than the excisional surgery, because really when you try to empty much fat, the patient will have like a sunken in the future. Maybe it will not appear in the first year or two, but on the long run, with aging, the patient will appear like having a hollow orbit. Uh, and really, if you compare the photos of young any person with his photos in the while like 10 years or 15 years ago, you'll find that the eyelids or the orbit is fuller than as we grow and grow older. So sometimes the fuller eyelid is a sign of young or rejuvenation. But the problem is that the bulges are demarcated, like a bulge and in depression, then a bulge and then depression. So maybe if you try to compensate this with a fat in the depressions and they all appear smooth, everything will look okay. And this is also the same that I follow in the patients coming for fillers or fat injections. I don't try to fill them. I don't try to make the cheek bloated or very full. I try to make the cheek smooth. Yani that, like there is depression, then there is elevation, then there is a tear trough, then there is elevation, then there is a depression here. So I, what I believe and what I do is that if by making the face smooth, you bring patients back to their younger look rather than by filling their face to be full like this. So this is what I do.
Yeah, that's what like even the younger surgeons has to understand this. Removing the fat is not the prime aim. To make there should not be any difference between the eye and the cheek. There should not be any like grooves or furrows in between the eye and the cheek. So it should be uniformly. It has to transform. Other thing is that, as Dr. Nadi said, most of the time we don't remove a whole fat. We remove a little bit of fat and we try to reposition the fat to the what is that, tear trough area. And sometimes, most of the time, that septa will be very weak. We try to tighten that septa so that that fat won't get prolapsed. We have to treat it like a hernia, not to remove the fat. We have to treat it like a hernia and like tighten that area so that the fat won't get prolapsed. And removing a little bit of excess skin. Sometimes some people, they have that orbicularis muscle will be a little more excess. So address it fully. Don't blindly and remove that bulge. We are going to remove all the bulge. If you remove, as Dr. Nadi said, that the furrows, that deep set eyes are very horrible looking and they look very older. Then like they'll be happy with that bulge than removing the whole fat. So you have to be very conservative in removing the fat, not much. I totally agree with you, Dr. Nadi. And
That's
what
true.
is, yeah, we found sometimes the little bit of, when they smile, no, that orbicularis muscle bulk will be seen in a lot of people's lower eyelid. A lot of actresses come and say that, doctor, when I smile, there is a bulge coming below my, like just below the eyelid margin. You can see, like the rolled up orbicularis muscle when they smile. A lot of people, they don't like it. Do you come across these kind of people in your practice, Dr. Nadi?
Not exactly, but there is because sometimes I tell you what I noticed really. Uh, some people, of course, when they find wrinkles in the lower eyelid, which is not a very common area of injecting Botox, but I inject the Botox in these people. and they improve. The wrinkles in the lower eyelid improve by 50%. But what I noticed that people who have very thin muscle in the lower eyelid, or very bulging, or some bulges in the lower eyelid, sometimes when you inject the Botox, this bulge increases. So this happens with me, like in one or two patients, and I learned from this that before I inject Botox in the lower eyelid, uh, I try to make sure there is a good tone of the eyelid, and there is a good muscle and no fat bags in the lower eyelid. Otherwise, because the muscle that is present, the orbicularis oculi that is present in the lower eyelid, serves a function. Maybe part of this function is to hold this fat back rather than leaving it bulging. So once you weaken this muscle, the fat bulges more. So that's what I learned while doing Botox, to avoid these patients from Botox of the lower eye.
It's very like interesting point, and you actually made it very clear, because even I have not I thought about it, because I also used to give a Botox a little bit for this kind of a bulges. It really works, but before giving for all the patients, you have to find out that there is no fat bulges. Otherwise, we ourselves weakening the orbicularis so that fat bulges become more prominent, and we are allowing it to herniate, as I said earlier. So sometimes I do, during the blepharoplasty, I remove a little bit of excess muscle in this region so that it will be addressed when you're doing a lower eyelid blepharoplasty also. So I address both the ways. Sometimes Botox for us, like when they're not willing for the surgery, only that is the only problem. And I try to give a little bit Botox, very small unit, maybe 1 or 2 units, not more than that. And if they are willing for surgery, along with that problem, they'll have that loose skin, or like lax eyelid, or fat prolapse, or teardrop. I combine with the surgery so that we can make everything at a time, and we can correct everything at a go. That's what I do. It's really interesting that this observation really I learned something from Dr. Nadi today.
Yes.
Dr. Joyce, any questions from you from the around the eye rejuvenation?
Uh, no, I agree with what he said. It is a very interesting point what Dr. Nadi brought out. We've seen a lot of these patients, and their main concern is one, the bulge when they are smiling, and second thing is that kajal which they put, the eyeliner, that smudges. So most of them, especially actresses, have that problem. So this is something nice which he brought out. We can explain to patients, there's a two-edged sword. If we put a Botox, like we can always weaken it and the fat can bulge. My question next to Dr. Nadi is with respect to the entire face. So suppose you get a patient who is having different concerns with respect to the face. What is that one thing you would like to correct first, which you feel will make them immediately will bring
Please,
a change and
the
look
sound
attractive?
is not very clear. Could
Dr.
you
Nadi,
repeat? Could
Dr.
you
Nadi,
repeat it, please? Yeah.
yeah, I said that suppose if a patient has various concerns on the face, what is the
Yes.
one thing that you would like to address first?
Dr. Nadi, the patient comes with various problems. Say we can take it like different age groups. Say example, 55-year-old female patient come to you with like she comes and tell you that, Dr. Nadi, make me more beautiful. Do whatever you want. And where you start, and what is your approach to the old lady, 55? 55 is not old, middle-aged lady coming to you for a facial rejuvenation. Where will you start, and how will you take it forward?
Yeah. Sometimes you are faced with a patient who comes to you and tells you I want tell me what my face needs to be beautiful, and then I come back to what I said before. I look at the face, and then I search for what makes this face deviates from the beautiful, and then I check the severity of every like, if you can call it deformity or something, we call it deformity. I arrange it from the more severe to the more moderate to the more mild. Then I arrange them, and I tell the patient, Actually, the first priority is that you can raise your eyebrow. Your eyebrow is much falling. And then I tell her the options. We have to raise your eyebrow. We have the Botox if you want a very mild elevation, or we have threads. We have like this and like this. Then I maybe the second thing I found very thin lips. So every patient is different, and every patient is different. Maybe you find a very young patient and have very thin lips, although these thin lips usually occur as the patient ages. But so we decide what is proper for this patient. Like you can say this patient you have full cheeks. Maybe you'll benefit from some buccal fat pad removal. Maybe you find that this patient has retruded chin. She will become much better if we put some filler or some fat to make chin protruding. So I arrange the priorities of the patient. I tell her this one, two, three, four will improve you, will bring you more beautiful. If you wanted to choose the four, it's okay. If you wanted to choose three, choose one, two, three. Avoid four. If you wanted to choose two, because already it's not a matter of the only of the patient's choice. It's a matter of how much the patient can pay, because these
That's correct.
treatments usually costly, and maybe the patient cannot afford to do all of them. So if you can afford to do two only, so do one and two, avoid three and four. So I try to, of course, I try to decide them in order of priority, because if the patient has to do one thing only, this one thing has to improve her to give her some improvement that she will appreciate. Because if she pay so much, yani if she pay much money and then don't find any result, of course she will not be happy, and I want her to be happy. If I don't find the patient need anything, I suggest for her to do cheek dimple.
I consider that whenever a patient comes to me, I tell them that three circles. First circle is the outer circle. Second circle is the around the eye circle. Third circle is around the mouth circle. I'll take it this way. So I tell them that first circle has to be upside down egg kind of. Like here it has to be broad. It has to narrow down like this. Okay, so what are the problems you might have? Okay, the filling the temple. Sometimes it might help you to broaden this area, because we lose the fat volume in the temple when we age. So I tell them here. Then I tell them that if your masseter is bulkier, you can use the Botox to reduce it. Or if the jawline is not proper, giving a fat or a chin implant or these things will help you to mold it better. So this is the outer circle. I tell them. Then around the eye, I'll tell them if there is any kind of a filler Botox needed to make it like uniform. And around the mouth also, I use the Botox and fillers to make it like better, and make it little bit like the idea is there should not be any furrows, grooves here and there. It had that the each area has to be moved to the other area without any kind of a groove, any kind of a sagginess. That is that's called the beauty, the youthful appearance. So I try to make them understand the three circles, and I'll tell them that most of them understand. They say, okay, this circle is bother me, that circle is bother me, kind of. I'll take it from there. Uh, Dr. Nadi, we had a very interesting session. Dr. Joyce, can you just, because almost 1 hour, people don't watch more than 1 hour, Dr. Nadi. So, Dr. Joyce, can you summarize what all the things we have discussed today, and then we finish today's live session, and we'll have some more discussion in the future upcoming weeks.
So today's topic of discussion was facial rejuvenation, and characteristically we thought we will be speaking about Botox and fillers, but Dr. Nadi brought out a very interesting thing, and that is about creating a cheek as well as a chin dimple. This chin dimple is something which we don't see our patients coming ahead and asking for. So he explained the procedure very well. It is done under local anesthesia. The risks are very less, and those who are interested can get it done easily. The other thing is, with respect to analyzing the face, it's important from top to down to analyze it thoroughly. Educate the patient, that is very important. See, those patients who come to us and ask us directly what they want, it is easy. But those who don't really know what it needs to be changed in their face, it's the responsibility of the surgeon to educate and tell them what is normal, what is abnormal, and what needs to be corrected. So that is something which he highlighted, and which, as cosmetic surgeons, we all like to tell our patients. So that is very important. And when it comes to correcting the different deformities, address the most severe one first, like he says, the one which can immediately bring a change or a rejuvenation to the face, and then take it ahead from that, depending on how the patient can afford or whether the patient is interested further. So
Yeah.
I think this is the highlight of what we discussed today. And Dr. Nadi, as Dr. Karthik told initially, you're a very good teacher. And for all young plastic surgeons like me, it's a very nice and educative session today. So thank you so much.
Dr. Nadi, thank you so much
Uh,
for today's session.
Thank you, my friend. I'm very happy that I joined you, and really I learned from you. And I hope we'll see each other soon. And we pray for our Indian friends to pass these hard times of COVID-19, and we can travel all the days as before. Well, thank you. Enjoy.
Thank you, Dr. Nadi. You guys,
Thank
please stay back. I'm ending the broadcast, but just please stay back.
Yeah.